It's a great honor for me to be with you again. I want to thank John Davis and organizing committee for inviting us. What we know about bladder neck sparing? We know very well from trauma cases, even in the absence of rhabdoid sphincter, bladder neck may help to continence or achieve continence in trauma cases. So why not in robotic prostatectomy cases? How we are going to preserve the bladder neck? How we are going to make a bladder neck sparing surgery? There are some tips and tricks. The first one is the tension of bladder, as we previously mentioned it. It's created by the fourth arm with the prograsp and retract the anterior dome of the bladder. That way you can see the shape of the bladder and the prostate more easily. And ureter catheter helps a lot not all cases, but especially in teen patients. The Foley balloon catheter, the spherical contour of the Foley balloon, may be more difficult to appreciate in obese patients who has greater amount of perivascular fat tissue. In my personal opinion, I don't use only balloon as a single reference point for bladder neck dissection. The first thing, you will remove the perivascular fat tissue. The second thing, you have to use a combination of sharp and blunt dissection to tease the bladder muscle fibers away from the prostate and in order to anatomically thin the bladder neck. After dissection, 270 and 360 degrees. 360 degrees better, but if you can dissect 270 degrees, that's fine. The ureter catheter balloon, you will deflate, as you all know, and you will cut the anterior fibers of the bladder. And the most important thing, I got the previous video, as you saw before, avoid use of monopolar cautery a lot. The first thing. This lessens the amount of tissue charring, preserve visualization of the native anatomy that allows for identification of bladder necks. You have to see, if you use sharp dissection, you have to see the bladder and the prostate exactly. And you have to see the natural plane. I don't use cystography in my bladder neck preserved cases. Let's see, it's one by one. The first thing is, this is a teen patient, but the first thing is you have to remove the fat tissue, especially it's an obese patient, around the bladder neck. The second thing, you have to pull the Foley balloon. It gives us some clue. Of course, we will use some cautery with monopolar or bipolar, but we have to avoid to use excessive cautery. I want to ask my colleagues, Kevin, do you get reference from the Foley balloon?
I think exactly those are the key steps of making sure that you...
Yes, the second thing is you have to come from the lateral sides, not to go only in the middle of the bladder neck. If you go just in the middle of the bladder neck, you will open. So you have to go from lateral sides slowly. You have to take your time. Another thing, he already published this. If you move with your progress, the bladder moves very easily. If you hold the prostate, it's not going to move. This is one of the first steps. And after you see the bladder neck, the other thing is it may not be easy in all cases. For example, in very large prostates, it's not easy to protect the bladder neck. And especially in medium lobes. If you have a big medium lobe, you cannot turn around 360 degrees. But once you identify the bladder neck, in this case, you're strong.
Yeah, so one of the tips I do in bladder neck sparing technique is I take the Foley catheter out.
I think this helps the continence a lot. This patient was completely dry. He didn't have even single one drop. Because I think the shape of diameter of bladder neck and the urethra, if they are equal to each other, the patient doesn't have, this is my personal opinion, doesn't have incontinence and urgency.
Well, it's beautiful. I mean, I think about it, you're going to distance your anastomosis away from the triangle, and you have a little artery. So the whole idea of the inflammatory response, the only thing that they may have is the Foley balloon inflammation of the triangle.
Now this is your time. We deflate the balloons and pull the folia out of round.
Nice.
Okay. Second part of the dissection, as well mentioned. So there are very different prostate shapes. It may differ from one individual to another one. It may be circumferential, like this, a round prostate. It may be symmetrical bilateral. It may be asymmetrical one. It may have a posterior lap or an anterior lap, or can blunt the end above the sphincter. So we have to think about, look at these results. There is no overlap only on 15% of cases. There is significant overlap of prostate tissue to sphincter in 85% of cases. Let's see some different video examples. The first one, this is a circumferential prostate. Go. What I believe in my case is the functional length of urethra is important. What do you say, John? I think the thickness of urethra is important for achieving continence in my patients. So I recommend not my colleagues and fellows not to dissect the urethra a lot, not to leave a thin urethra. I think we have to achieve the thickness of urethra as very important.
That's a very tight anatomic space you work in to try to maintain urethral length thickness and release the really the pillars of the rhabdosphincter as close to the prostate as possible, so when they retract back, they're still on the remaining urethra as much as possible. You should be able to stick an instrument in the prostatic urethra and see the vira would be right on top of that.
Yes. To preserve the maximum length of the functional urethra, these anatomic variations have to be considered during the individualized preparation of apical structures. Sometimes my colleagues, my friends in Turkey, they ask me, they said that I do the same operation to all my patients. One of them is continent, the other one is not. I don't understand why. I say that the answer is in your question. You do the same operation to all of your patients. You have to change your operation. You have to see the anatomic variation of prostate. We will see two examples of different prostate. Now, the first one is the change, the prostate anatomy may change. There may be different anatomies, for example, in this case. So we have to adapt and change our cases to one individual to another one. We have to look at the prostate anatomy very carefully. In this case, after cutting the dorsal vein, you see a prostate nodule on right side. If you cut it from here, this part, this nodule will remain on urethra side and the patient probably will have a rising PSA.
If you want to pause, I would say one just quick personal note when I'm training the fellows on the apex right there is to think of the exposure in 3 lines of sight. So one is the midline site where the third arm is pulling straight in line with the urethra and you cut for a while. And then the other 2 are on the side, so you would have the arm grab, so on the left side you would grab the prostate at 3 o'clock or really 9 o'clock on the base and rotate it over so you can see along the side. You should be able to connect it from the nerves, then you go the other side. So think of 3 different exposures, 3 different dissection planes and that's how you, back to his question of how do you maximize the urethral length, you have to attack it from 3 angles and sweep it back to get to this point where you can see on the right side the nerve bundle's off and out of the way, and you have to get to that point to do it.
So this really is the Pandora's box of so many different things within a short amount of time.
Okay, I will show you another example of one of my cases. And
you were looking at it from the side, and then you went back to this side now. There you go.
just, could you please join me? How many of you, please raise your hands, will cut the urethra? You see the prostate is here, up to here. We'll cut the urethra from here. Majority. Okay? So that means let's wash the rest part. That means the patient will leak, will have incontinence. See? Okay. If you look closer to the prostate, the urethra goes up to here, not here. You see? Did you realize? So this is an anatomical variation. If you cut in all your patients, in low-risk patients, I agree with Kevin, if you cut them from here, the patient will be incontinent or will leak. The urethra goes up to here and the sphincter also. Let's see with the diagram. This is exactly what this case is. What you did, you cut from here. Okay? Majority of you. So you sacrifice at least 40%, 50% of the urinary sphincter. So your patient will have leakage. So that's the key point. We have to look at the anatomy of prostate very carefully, and we have to adjust to our patients. I don't mean in apical tumors, but in low risk or medium risk patients, we have to organize this is the specimen how it looks after the operation. You see the prostate lateral lobes, and I remove only the urethra. You see exactly. But I don't do this in my cases who has a gross apical tumor in MRI, or only biopsy positive in apical part of the prostate. But the issue is to remove the urethra from the inside the prostate.
Kevin, why don't you talk to some of your